Hello doctors. Today our topic of discussion is head trauma. Head trauma is the most common cause of mortality following trauma. Most common cause of mortality is our head trauma. So we will start with the anatomy of skull, like anatomy of scalp. Okay. So starting with this, number one, we have the skin above. For the scalp, this is the skin. Number second, we have connective tissue. This connective tissue have septations. Walls, there are present, septations are present here in the connective tissue, and we have the blood vessels inside these. Walls of the blood vessel are adjacent to the fibrous septa and blood vessels cannot constrict. Here, therefore, because of septation, blood vessels cannot constrict in this region of connective tissue. Therefore, bleeding continues. Okay. Now, number third, we have aponeurosis. Bleeding vessels of the aponeurotic layer causes black eye. Okay. And number fourth, we have loose areolar tissue. And number fifth, we have periosteum. Okay, this loose areolar tissue, this layer, loose areolar tissue, have emissary veins. In them. And emissary veins causes later on, it is connected to cavernous sinus. So it might cause cavernous sinus thrombosis. So this is the anatomy of scalp, which have the first layer skin, connective tissue, aponeurosis, areolar tissue, loose areolar tissue, and periosteum. Now we will see scalp lacerations. Up now, scalp laceration and scalp fracture. Scalp laceration have we can do emergency management. What is the emergency management? If a patient comes to you with a bleeding scalp, then first we will apply pressure. This is the emergency management. And definitive management is we have to suture. Either we will suture with silk or with nylon. 20, 30. Either we will use cutting needle or we can use reverse cutting needle to suture the wound. Now we will see the skull fractures. Skull fracture, as you know, the skull fracture can be depressed type and non-depressed type. Now, depressed, here in the image, this is the depressed skull fracture. In depressed skull fracture, we have to see if there is any focal neurological deficit present or not. We have to see if there is any focal neurological deficit. If depression is more than adjacent area or not, we have to watch the patient. In non-depressed skull fracture, no surgical management, and we have to just observe the patient. Here we might need surgical management if focal neurological sign is present. Now we will see a very important topic, that is the base of skull fracture. Now, base of skull fracture, we can have three types: anterior cranial fossa fracture, middle cranial fossa fracture, or the posterior cranial fossa fracture. In the anterior cranial fossa fracture, there is mainly fracture of cribriform plate. Okay, and what are the sign? The clinical features of anterior cranial fossa fracture is number 1, black eye, which is also known as raccoon eye. Here in the image we can see this is the black eye. Black eye is associated, can be associated with subconjunctival hemorrhage. Subconjunctival hemorrhage, and it happens in the anterior cranial fossa fracture. Superior limit is generally not visualized. Now, apart from the black eye, what else we can see in the anterior cranial fossa fracture? We can see CSF rhinorrhea and we can see epistaxis. How will you differentiate between CSF rhinorrhea and epistaxis? We can differentiate these two by this. This is the handkerchief sign or target sign or halo sign. This is seen in CSF rhinorrhea. One test is this one, and the second test is in CSF beta 2 transferrin is present. In epistaxis, in blood, beta 2 transferrin is absent, but in CSF beta 2 transferrin is present. So this is the difference between the CSF rhinorrhea and epistaxis. Apart from that, we can have anosmia and we can have frontal lobe contusion. These are the clinical features of anterior cranial fossa fracture. Now we will see the middle cranial fossa fracture. In the middle cranial fossa fracture, there is fracture of petrous part of temporal bone. And what are the clinical features of the middle cranial fossa fracture? Number 1 is the temporal lobe contusion. Number 2 is battle sign. This is the battle sign. Discoloration of behind the ear, there is discoloration, and this happens generally 24 to 48 hours after trauma. It doesn't happen immediately. Number 3 is hemotympanum. Number 4 is CSF otorrhea. Number 5 is facial nerve injury. Number 6 is paradoxical rhinorrhea. In anterior cranial fossa fracture, we have seen CSF rhinorrhea, but in the middle cranial fossa fracture, there is paradoxical rhinorrhea. What is paradoxical rhinorrhea? In paradoxical rhinorrhea, CSF accumulates in middle ear. Okay, and from the middle ear, as you know, middle ear have Eustachian tube. Via the Eustachian tube, the CSF from the middle ear comes out from nose. So therefore, this is known as paradoxical rhinorrhea. Now, posterior cranial fossa fracture. In the posterior cranial fossa fracture, we have fracture of occipital bone. Posteriorly occipital bone is present. The fracture of that happens in posterior cranial fossa. Number 1, occipital is major for there will be visual problems. Then we have occipital contusion. we have sixth nerve injury, and number fourth important is we have Wernicke sign or Wernicke syndrome. Wernicke syndrome is also known as jugular foramen syndrome. As you can see in the image, this is the jugular vein, and near the jugular vein we have the 9th, 10th and 11th cranial nerve. So what is jugular foramen syndrome? In jugular foramen syndrome or Wernicke syndrome, there is injury to 9th to 11th cranial nerve. So this is what we have to know in posterior cranial fossa fracture. Now we will see the NICE guidelines. What is NICE? Full form of NICE is National Institute of Clinical Excellence. So this is the full form of NICE, National Institute of Clinical Excellence. So what are the criteria that are present in NICE? Number 1, suspect cervical injury in all patients with head injury. We have to suspect they have cervical injury until unless we have done the X-ray of neck. So number 1 is suspect cervical injury in all patients with head injury. Number 1 is this. Number 2, we have to know how frequently GCS is monitored. We have to know how frequently GCS is monitored. This is asked in many times in MCQ and even in your UG and PG exams of surgery. So you have to remember in first 2 hours, every half an hour. Every half an hour you have to go to the patient and see the GCS. Number 2, in next 4 hours, we have to see every 1 hour. In after 6 hours, as 6 hours has happened, we have to see every 2 hours. So first 2 hours we have to see every half an hour. In next 4 hours, every 1 hour. In after 6 hours, every 2 hours. Number 2 is this one. Number 3 is indication to involve a neurosurgeon. When we have to call the neurosurgeon in casualty or trauma. Indication to involve a neurosurgeon. Number 1, if GCS is less than equal to 8, then we have to call the neurosurgeon immediately. Number 2, fall in GCS after admission. Fall in GCS after admission. Suppose for example, when your patient have came, you have calculated the GCS and you have seen the patient has a GCS of 15. After few minutes or hours, the patient GCS become 13 or 12. Then we have to call a neurosurgeon as there is trending in fall in GCS is present. Number 3, unexplained confusion. Unexplained confusion for more than 4 hours. Then also we have to call the neurosurgeon. Now number 4, if patient have a history of loss of consciousness, if patient have a history of seizure, if patient have history of vomiting, ENT bleed from ear, nose or throat, there is any history of any kind of bleeding is present. Number 8, focal neurological deficit, and if there is penetrating CNS injury. Okay, so what are the indication to involve a neurosurgeon? GCS less than 8, if there is fall in GCS, unexplained confusion, loss of consciousness, seizure, vomiting and ENT bleed. These history you have to must take a patient of a trauma. And then focal neurological deficit and penetrating injury. Now we will see the NICE guideline. This is the third. First is we have seen the cervical injury. We have to treat every patient of head injury as have a cervical injury. Then how frequently you have to calculate the GCS. Now this is the indication to involve a neurosurgeon. Number 4 is when to do NCCT head in patient of trauma with head injury. Number 1, this is important. GCS is less than 13 at any point, then you have to do NCCT head. Number 2, when GCS is less than 15 at 2 hours. First it was 15, then after 2 hours it decreased. Then also we have to do an NCCT head. Number 3, focal neurological deficit. Number 4, suspected open depressed or basal skull fracture. GCS less than 13, GCS less than 15, focal neurological deficit, suspected open, depressed or any kind of skull fracture. And number 5, more than one episode of vomiting. More than one episode of vomiting. And patient if has a history of seizure after trauma or during trauma. Okay, so in all this indication, the CT done within 1 hour. We have to do the CT of the patient within 1 hour after coming to the hospital. And there is another NICE guideline where CT is done within 8 hours. This was for 1 hour and this is for 8 hours. When to do CT within 8 hours? Number 1, if the age is more than 65 years. Number 2, coagulopathy. If patient is taking aspirin or warfarin or rivaroxaban or any kind of anticoagulant, then we have to do CT scan within 8 hours. If patient have retrograde amnesia for more than 30 minutes, then we have to do the CT scan. And if there is dangerous mechanism of injury, like fall from height or road traffic accident, then within 8 hours we should do CT head. So we have seen the CT head guidelines. Now, according to NICE criteria, when we have to discharge the patient, when we will not admit the patient of head injury. Number 1, as you know, if the GCS is 15 by 15 with no focal neurological deficit. Number 1 is this. Number 2, normal CT brain. We have done the CT head and it is normal. Number 3, patient not under the influence of alcohol. Patient have not taken any kind of alcohol, no alcohol or drugs. Patient accompanied by a responsible adult. When you are discharging him, the patient must accompanied by a responsible adult. Then number 5th is verbal and written head injury advice. What are the advices? Seek medical attention. We have to advise the patient, and we have to write it also, and we will tell the patient verbally also that persistent or worsening headache. If the patient have headache, persistent headache or worsening headache, then patient must need to come to the hospital. If there is persistent vomiting, then if the patient have persistent drowsiness, if there is visual disturbance at any time, and if patient have limb weakness or numbness, then patient must need to come to the hospital. So what are that? Headache, persistent vomiting, drowsiness, visual disturbance, and limb weakness. So these are the nice criteria when to discharge the patient. So we have seen and studied a lot today. First, we have started with the anatomy of scalp, 5 layers of scalp, 5 layers of that. Then we have seen the scalp laceration, we have seen the skull fracture, we have seen the base of skull fracture, anterior cranial fossa fracture, middle cranial fossa fracture, posterior cranial fossa fracture. We have seen the NICE guidelines, starting with the cervical injury should be suspected in all patients with head injury, then when to calculate GCS, indication to involve a neurosurgeon, indication to do CT within 1 hour and after 8 hours, and when to discharge the patient. So thank you for watching this video. In our next video, we will cover the component of GCS and brain injuries, and we will continue with the trauma. Thank you guys for watching. If you like this video, do support me by doing a like and subscribe to this channel, and don't forget to click on the bell icon. Thank you.